Hello, I'm Dr. Maury Markman from City of Hope. And in the last segment of Minutes with Markman, I sort of emphasized the past, which wasn't that long ago, where new advances in oncology came along. They were real, but they were slow. I could think about them. They were measured over in many diseases over a period of years before we had new advances. Trials were actually quite similar, even if there were multiple groups that were doing the trials. Plus, it was important to point out that in those earlier days, with the exception of hormonal therapy, essentially all the drugs were variation of a theme, cytotoxic drugs. And although there were certainly exceptions like doxorubicin, which had cardiac toxicity, and a few drugs that actually had serious renal toxicity, like cisplatin, most of the drugs had similar side effects: nausea, vomiting, fatigue, and of course, impacts on bone marrow function. As a result, the choice of therapy for an individual doctor, for an individual patient in terms of the toxicity pattern really was very similar. And mostly what you'd look at is did you need to modify the dose and schedule? So the drugs were really quite similar. Efficacy obviously is a different question, but the toxicities were really similar. But today, with the truly revolutionary changes, and I don't use that term lightly, in our understanding of the molecular biology of cancer, we have an increasing number of novel targets, novel drugs, diagnostic platforms, including the rapid advances in liquid tumor biopsies, which are going to revolutionize how we think about therapy and changing therapy. And we have an increasing number of tumor agnostic drug approvals, where knowing the molecular biology is what's important, more so than even the site of origin. Add to this the fact, the absolute speed of approvals by regulatory agencies done appropriately simply do not permit, there's no other way of saying it, clinically meaningful comparisons of strategies that have been approved that impact individual patient care. In the last segment, I talked about the control arms of trials. They were all kind of similar in the area. Now a trial gets finished, and when asked the question, yeah, but the control arm of that trial, which was started only 3 years ago, was out of date by the time the trial was finished. How do we interpret these results? That is because of the speed at which things are moving along. And to add to this, to pile on the complexities of oncology care, we have the remarkably and distressingly divergent insurance policies that impact what patient A is able to receive versus patient B versus patient C. This is not only in terms of the drugs that are now proprietary, but we're talking about generic drugs or biosimilars. We also know that cancer in many areas is becoming increasingly a chronic disease process, where survival and potential treatment is no longer measured in months, but now often in years. So we have therapies that are being given for long periods of time, prolonged periods of time. How does an oncologist, who is not a super specialist in a very individual cancer type, care optimally for individuals outside of that setting of that narrow focus? I would argue this is increasingly becoming difficult, if not impossible. It's not the goal of the oncologists. They all want to do their best for their patients. But with the stream of information that is coming forward, how does one do this? Finally, one must add, and I would argue that what I'm going to say now has been given totally inadequate attention, but must add that cancer, as we all know, is mostly, although not exclusively, a disease of the elderly. And as the population ages and more patients develop cancer and are being cared for cancer, that only increases this issue. And in addition, we now have agents where we can give therapy, provide meaningful therapy to patients in their 70s, 80s, or even older. And individuals that I'm describing don't have only cancer. They often have. In fact, it's more likely than not, they have other relevant comorbidities: cardiac, pulmonary, renal, hepatic, that may influence the therapy they're getting and the medications they may be taking for those conditions. What is the impact of those medications on the cancer therapy and on the cancer therapy on those medications? We have just scratched the surface of the impact of this. These are very serious considerations, and I would suggest we need to come up with a far better way of treating our patients to take all of these issues into consideration. On the final segment, I wish to provide a provocative suggestion for a potential future direction in providing decision support. And I thank you for your attention.